Good morning, and many thanks for coming on. Is that okay? Can you hear me at the back? It's coming out clearly. Great. Great, that's come up. As Bill mentioned, apart from being Deputy Director of UK NEQAS for Blood Coagulation, I'll give you some information just now about all our point-of-care testing programs that are run through the various centres. I'm also the Chair of the point-of-care working group, and the idea is that we're bringing together all of the UK NEQAS programs that are currently offering or are looking to be offering point-of-care testing to help coordinate things. Bill's mentioned about the website. I've got a couple of slides showing the point-of-care section of the new website, and I do encourage you to go to the new website for information. I'm based at the Hallamshire in Sheffield, where also, as you'll see, we've got a couple of other programs. One, leukocyte immunophenotyping, is also based at the Hallamshire, and immunology, where Bill's director is over, and Dina, deputy director, is over at the Northern General in Sheffield. So to kind of kick off, to paraphrase John Cleese from The Life of Brian, it's not what have the Romans done for us, but it's what can UK NEQAS do for us. And this was a case, it is a few years old now, this is 2001, but in the United States, St. Agnes Hospital in Philadelphia had a situation where they were finding that the INR, and I'll just show this. I'm not trying to turn those of you who want clotters into clotters, but this kind of has some relevance, kind of with just the next bit of this talk. The INR, International Normalized Ratio, is the prothrombin time of the patient divided by the mean normal prothrombin time in seconds, and that gives a ratio, which is then raised to the power, and that's quite important, of the ISI, the International Sensitivity Index. Now, normally, this calculation is made by the laboratory coagulometer or point-of-care testing instrument that's being used with data from the thromboplastin manufacturer, the reagent in the test, and it's automatically kind of churned out in the result. What actually happened in Philadelphia at St. Agnes? So there were 932 patients found over 7 weeks, and unfortunately 5 deaths occurred that were needed to be investigated, of course. One patient questioned their escalating Coumadin or warfarin dose, Coumadin in the States, and because they didn't feel that it was right, the result that was coming out for their INR, which is used to monitor their Coumadin dose or warfarin dose. And a patient with an INR that was told it was 2.6 at St. Agnes in Philadelphia found they had bleeding from their gums, and that certainly shouldn't be the case. 2.6 is a normal kind of therapeutic INR for a number of conditions. But when this patient went to another site, they found that the INR was 5.7. And what had actually happened is that a reagent with an ISI, if you remember, that's the power that's used to raise the ratio of the prothrombin time to. This was used for the testing, but in North America, it used to be normal for an ISI, a higher ISI of 1.8 to be used, but more so in Europe, we've used an ISI of about 1 in thromboplastins, and the instrument that was used had 1 in there, kind of in the actual calculation for the system. And of course, this was giving incorrect results, meaning that the patient was receiving far more warfarin than they should have done. It did go to court. The hospital was fined very heavily. And of course, it was a terrible situation for those people and families affected. So this is the kind of thing that we can pick up through UK NEQAS, through external quality assessment. And I'll come on to that a little bit more. So really, is there a difference between laboratory and point-of-care testing? And how big is point-of-care testing? If we call UK NEQAS testing the testers, in point-of-care programs or in our oral anticoagulant control program, with about at least 4,500 getting on to 5,000 participants, we have 64% of the testers are nursing professionals, and only 3% are biomedical, clinical, or laboratory scientists. And that's a total reversal for our laboratory program, where 99% of our participants are laboratory scientists, clinical laboratory scientists, who are, of course, more used to IQC, internal quality control, and EQA. That's not to say, of course, that we don't get good results from nursing professionals, pharmacists, healthcare assistants. We do, and Di Kitchen later on will show some information from Blood Coagulation. A number of our programs have got information, case studies from the various point-of-care programs that I hope you'll find really interesting as we go through the day. But it is more that we've been more akin in the laboratory to quality control in general. But thankfully, it is changing, and we're kind of getting the word out there. But the global POCT market is still a small proportion of the overall clinical laboratory market. It's estimated by market researchers that it's about £13 billion, or $16 billion last year in 2016. And this is set to grow 10%, that's the CAG, it's the combined or compound aggregated annual growth rate. It's set to grow to £28 billion or $36 billion by 2021. But the laboratory market for testing, diagnostic testing, is much larger. So it's still growing. And we've certainly found that in coagulation. We've had a really exponential growth in a number of years with participants in the program. Now, without trying to teach grandmother to suck eggs, as it were, just going back to basics, internal quality control, or IQC, generally it's purchased from a commercial manufacturer, often of the testing device, and it compares the result that you obtain on your system to a range. That can be specific for the particular testing device, but sometimes it's quite wide, the range that you're kind of allowed to get within for IQC materials. And it really addresses the question, are my results the same today as they were yesterday? Or if you're in a large clinic running IQC materials a number of times a day, is it the same each time during the clinic? EQA, on the other hand, is a service from an external organisation, such as UK NEQAS, that compares your result from those of other users. And often we can do that with large numbers in our databases, a large number of users. We can compare your result against specific devices and technology. So in point of care, it's specific instruments. We run programs for individual devices. And addresses the question, are my results the same as other centres that are doing the same test? There are generally onboard QC facilities in point-of-care systems, and these are a function of the device. It checks the test strip, and it's useful for strip integrity. Often they're electronic checks, so they don't give full results. They don't show the full result and range that's expected, and they can't really give information on strip calibration. They're useful, but other forms of IQC and EQA are required. Control samples, as I mentioned, usually from the equipment manufacturer or an independent supplier. Now, Bill's already introduced UK NEQAS. I won't dwell too much, but I wanted to just give a few figures background. We're a network of more than 400 EQA program services, operating from more than 20 centres, about 23 centres in England, Scotland and Wales. So around the country, based at major hospitals, research institutions and universities, with a role to improve the quality of testing and thereby improve patient care. And as is always mentioned in financial adverts, other EQA programs are available, as well as other finance programs. So we're an NHS organisation, as I mentioned, majority based at teaching hospitals or academic institutions, not-for-profit, funded directly by participant fees for the operation of the programs. And Bill's mentioned that we're in over 130 different countries, or a large number of countries. Oversight for the participation in the programs is overseen by a steering committee for each program. And then the steering committee reports through to National Quality Assurance Advisory Panel for each speciality. There's chemistry, hematology, microbiology, immunology, etc. And then those NQAPs, as they're called, also report through to what is now the Joint Working Group on Quality Assessment in Pathology, and then ultimately, of course, the DH. Bill's shown the wide range of our participant base internationally. So UK NEQAS really, as we've said, it benefits patients as well as the participants. It's the main aim to benefit patients. It's clinically focused at decision-making levels with an aim to educating participants. And that really is a strong ethos across UK NEQAS programs, is the role of education role. With meetings, Bill's mentioned, we're having a number of other ongoing programs that will be coming in to assist and develop feedback from participants on two-way. With networking and sharing best practice and harmonising practice where this helps, with benchmarking, and I've already mentioned working with those oversight bodies. A couple of slides here combined two of the web pages in the new website. I mentioned we've got a point of care area where you can go to see which programs are actually included. We've got a talk later on from Delia Geary from UCAS, so we can call UCAS really checking the checkers, if we're the checkers, and as well as the testers in those participants. UCAS, for EQA programs, the ISO standard is 17043, general requirements for proficiency testing. We have, similar to the 15189 program, full reassessment every 4 years, surveillance every year, with an initial surveillance visit 6 months after the initial grant of accreditation. And our UK NEQAS Code of Practice requires that all programs achieve accreditation to UCAS now. So just a quick review of the programs we have within point of care programs. Blood coagulation, I've already mentioned the oral anticoagulant program. We have an ACT module, D-dimer for point of care testing, and ROTEM and TEG, the rotational thromboelastometry and thromboelastography. LI, I mentioned leukocyte immunophenotyping, have immune monitoring with alternative technologies. Cardiac markers based in Glasgow have extensive point of care programs. Clinical chemistry have urine dipsticks and health checks, as well as chemistry in Edinburgh, peptide hormones. Kathy Sturgeon is talking later on. Urinary HCG, qualitative and quantitative. Microbiology, HIV point of care. And we have general hematology incorporates the point of care devices within their main program, laboratory program. Immunology, you'll hear from Dina talking later on about a new program launched just last month for C-reactive proteins. So that's an exciting innovation. And we will have, as I mentioned, more programs coming on. So just in conclusion, we feel very strongly that both IQC and EQA are required for point of care devices. Participation in an accredited EQA program is recommended and it's been shown, can improve all aspects of point of care testing. There are beneficial reasons for the establishment of connections, good connections with liaison with the local laboratory for point of care testers. And accreditation, as I said, Delia is going to talk further about this, about point of care testing accreditation, as well as Sarah. Sarah Glover will give their experience in Harrogate. But one problem is, at the moment, as I'm sure a lot of you are aware, is that to achieve point of care accreditation with UCAS at 22870, 2016 is the new set of standards that took over from 2006. But you have to get 15189 as well. There's not a standalone set of standards for point of care accreditation. So we hope that in the future that will change, and Delia's smiling at me. The UK side actually is very strongly pressing for this, but our European brethren, shall we say, are perhaps a little less keen to. But thank you very much indeed, and please enjoy the rest of the talks that will explain a lot more. And just to show as a last slide that UK NEQAS supports each year Healthcare Science Week, which is a long week, 10th to the 19th of March. 9 days in a week for healthcare science next year. But thank you very much indeed.